a potential possibility, yes. So let me get that this thing. I mean, was there a maculopapular rash involving the palms and soles?
Yes, sir.
I thought, was there involvement of the palms and soles?
Yes, sir.
Okay. If it was involving the palms and soles, then very, very likely that it would be spotted fever rickettsiosis.
And that too, particularly when you suspect rickettsial, doxy is the first choice rather than azithro comes down the lane. Actually, it is azithro is not a good choice when you are suspecting rickettsial starting as a empirically.
Okay.
Pandiraman sir, azithro will cover enteric, azithromycin will cover rickettsial, azithromycin will cover mycoplasma.
But still, when you
Yes,
start as a trial for 48 hours, doxy is the choice.
I also would go with doxy, and doxy will also cover mycoplasma. So,
thank you, Dr. Sharmila, for that lucid presentation. Can we have the second presentation, please?
Thank you, sir.
Dr. Divya, please move on to the second presentation. Divya, can you move on second presentation, please?
Yeah. We now invite Dr. Nagardarshini, a postgraduate under Professor Jayavardhana from Coimbatore, to make the presentation. Doctor, over to you.
Good evening, everyone. I am Dr. Nagardarshini, Senior Resident in the Department of Pediatrics, PSG Medical College, Coimbatore. My presentation is about a 9-year-old developmentally normal male child who was admitted to us with complaints of fever for 5 days, which was high-grade intermittent, not associated with chills or rigor. Rash noticed on from day 3 of illness over the trunk, altered sensorium since 1 day, and with 1 episode of seizure before arrival. At admission, he was in gasping state with hypotensive shock. Next slide. So this was the rash which was noticed on day 5 of illness. It was diffuse confluent erythematous maculopapular rash, which was noticed over trunk, which was blanchable on pressure. He did not have any eschar, edema, or lymphadenopathy. His cardiovascular and respiratory system examination was normal. No organomegaly was seen. CNS examination, his pupils were sluggishly reacting to light. He was hypotonic with bilateral extensor plantar. So with the picture of rash with acute febrile encephalopathy and hypotensive shock, we considered 3 differentials, which was initially it was rickettsial vasculitis, toxic shock syndrome, and dengue shock was considered.
Divya, please slide, please. Divya's move slide.
No, so the previous slide only. So the previous slide only. Yes, sir. So we consider differentials of scrub vasculitis, toxic shock syndrome, and dengue shock syndrome. He was intubated and mechanically ventilated. He received fluid boluses followed by inotropic support. He was initiated on broad spectrum antibiotics after sending cultures within 1 hour of admission. He was given anti-seizure medications along with anti-edema measures. So next slide.
Next slide, please. Divya, next slide.
So next slide, please.
Divya, next slide.
the PDF opened, not a PowerPoint.
So on day 7 of illness, that is on day 3 of admission, child started to have gangrenous changes over extremities, along with a non-palpable purpuric rash which was noticed in his lower limb, following which we revised our diagnosis to rickettsial vascular. Next slide, please. So we revised our diagnosis to rickettsial vasculitis, meningococcemia, sepsis with DIC. Next slide, please. So the points favoring towards scrub vasculitis in our case was there was history of tick exposure with elevated transaminases. He had acute kidney injury at presentation. He had thrombocytopenia with elevated CRP. And points favoring dengue shock syndrome was that he had normal counts with thrombocytopenia with elevated transaminases. And for toxic shock syndrome, the child had fever with hypotension with involvement of 2 or more organisms. Our child had involvement of liver, kidney, CNS involvement. So to summarize, he had encephalopathy, hepatorenal dysfunction, severe thrombocytopenia, DIC, and cardiac dysfunction. The investigation part, CSF analysis could not be done because of unstable hemodynamics. CT brain done was normal. Dengue serology and scrub serology turned out to be negative. Blood culture done at admission was sterile. Next slide.
Thank you, Dr. Darshini. We can stop the presentation here for a while.
Okay,
I can request Professor Winsley to give us his comments. This is quite a remarkably different case scenario from what was previously described. This is an acutely unwell child with a generalized rash and multiple organ dysfunctions with rapidly developing pregangrenous changes. Dr. Winsley, would you consider specific infection in this scenario, or are you happy with the differences that Dr. Darshini has proposed? Dr. Winsley?
Dr. Winsley, unmute.
Sorry, I didn't unmute myself. Sorry. So it looks like the fever has gone on for 5 days, and then only the patient is actually presented with shock and altered sensorium. So that makes it less likely to be a toxic shock syndrome rather than compared to a rickettsial infection or something like that. So with the progression of this illness to gangrene by day 7, all of that suggests a fever with vasculitis, which is more in keeping with a rickettsial infection than anything else. So I would actually concur with the suspicion that it was a rickettsial infection. And again, it could very well be spotted fever rickettsiosis also, which can actually present with fever and a vasculitic rash. It need not necessarily be scrub typhus. So one possibility that we are missing all this is because we do scrub IgM, but we don't do a spotted fever IgM. So and about 10% of all spotted fevers actually is present without spotted fever, spotted rash. So I think that is probably my first consideration. I'll wait for the others to comment and then we'll take forward.
Dr. Satish, is it possible for SLE or HLH or macrophage activation syndrome or some systemic vasculitis which is non-infectious to present in such a hyperacute fashion? Would we consider CNS vasculitis in this child?
Yeah. So the only disease in rheumatology which can present like this acutely with deterioration with multi-organ failure is SLE. But the infection comes first. You rule out infection, wait for 48 hours to wait for the antibiotics to settle. If not, then you should consider SLE workup for this child. And HLH part, any infection can precipitate a HLH. So somebody has got pancytopenia, this type of presentation, I think ferritin has to be added as a diagnosis when the child comes with shock. If the ferritin is more than 10,000, definitely HLH, whatever the reason, whether it is infection, malignancy, or rheumatological condition, that has to be treated. So my suggestion will be infectious workup, as Vinci said, and ferritin has to be done when somebody comes with multi-organ dysfunction with shock.
Point well taken. Dr. Paniraman, if you are the person who is receiving the child in the ER, as a general pediatrician, what would be your first line of stabilization of the child before you refer, if at all you want to refer? What are the things that every pediatrician should do when a child presents so hyperacutely?
Oh, this is actually given the situation of shock and hypoxemia and everything associated things. Naturally, the ABC has to be taken care of, and mainly the oxygen, and start an IV line and try to push a bolus of IV normal saline and 1 or 2 boluses and try to build up the hypotension and give the first dose of antibiotic. Given the nature, we may be dealing with a toxic shock syndrome, or because of the erythrodermal rash, along with the hypotension, along with the encephalopathy, the first choice will be the toxic shock syndrome. So even though it is a toxin mediated, but still antibiotics like ceftriaxone can be given in this child. Then because ceftriaxone is going to cover the meningococcus also, even though it doesn't look like a meningococcal rash, it is a thing. The thing we have to start. So give the first supportive management, oxygen, IV fluid, then the first dose of antibiotic, and try to stabilize and then refer.
Antibiotic or antibiotics? Will you consider giving IV doxycycline also?
Yeah,
considering the
definitely
side
doxycycline. If you are because this Kahn-Kappe disease is the disease particularly known in Maharashtra and North Karnataka, which is very common to present like this, with the gangrene affecting the extremities and the ears and everything, which is not so common in our part. And particularly scrub typhus presenting like this will take only in the 2nd week or 3rd week. 2nd week, particularly at the end of the, they'll go for ARDS or like all these vasculitis things. Only the spotted fever will present like this, and that too at the end of the 5th day, 6th day. So doxycycline empirically we can start. Yeah.
Okay. Thank you, panelists. Dr. Dashni, can you go ahead and tell us what you did?
Sir,
Dr. Dashni?
initially airway and breathing were maintained, and he required fluid boluses followed by inotropic support, sir. We started him on broad spectrum antibiotics, meropenem, clindamycin, and vancomycin, considering toxic shock syndrome, and he was started empirically on IV doxycycline for rickettsial infections, sir. So, and for AK part, he was initiated on CRRT on day 3 of admission, and the DIC part was managed with heparin infusion, sir. So later, after 5 days of hospital stay, the child's hemodynamics improved, and we were able to taper off inotropes. Gradually, he was extubated after 2 weeks, and we were able to
get an
discharge the
etiological
child.
diagnosis?
Sir?
Could you get an etiological diagnosis? We know you have done a wonderful job in managing this very sick child, but
Yes.
what do you think was the thing that actually turned the corner? Do you think it's the broad spectrum antibiotic, the supportive care? Do you still believe it may have been gram-negative sepsis or toxic shock, or do you think it's rickettsial illness where doxy? What do you think actually helped this patient come out?
We were not able to I isolate any organism from cultures, sir. We sent repeated blood cultures. We tried to we sent a throat culture which revealed staph aureus growth, other MRSA growth. Other than that, we were not able to isolate any organism. Scrub IgM was sent twice, which was negative, and dengue serology also was negative, sir.
Okay. So we'll close this session with Professor Jayavardhana's words. Dr. Jayavardhana, would you want to add anything to what Dr. Dashni said? What were your thoughts as the lead consultant in taking care of this child?
Thank you, sir. As we are trying to understand, we first of all infection. We started the type was a zero negative. We started.
Your audio is not very clear, Dr. Jayavardhana. Can you make yourself louder, please?
Ashwath, video on பண்ணிடுப்பா.
Clear, sir?
Yeah, better. Thank you.
Our first diagnosis was spotted fever, sir, infection. So we started doxycycline from day 1. And we also covered with the broad spectrum antibiotics, vancomycin. I'm not sure whether we just say, but we gave vancomycin, clindamycin, and meropenem we gave. Child responded well. And after 5 days, we were able to graduate after the inotropic support and fluid etc. Only thing that slightly pointed out, we should not go with a IgM model, but we have to go for a spotted type IgM. In fact, I don't know where is that.
Thank you so much for your inputs. Can we move on quickly to case number 3? Thank you.
While the case is loading, can I just comment on that?
Yes, please.
Yeah. So I think like when a child comes sick like this, I think the empiric antibiotic choice, especially in a 9-year-old, I think the best good thing would have been to give vanco, ceftriaxone, and doxycycline. I mean, given that, I mean, these are all the things that we've talked about. I mean, there was toxic shock syndrome, there was meningococcemia, there was rickettsial infection. So all of them are the things in the mix. Often what happens is people give vanco, mero, clinda, doxy. But I think probably the most appropriate would be vanco, ceftriaxone, and doxy, keeping in mind that it will cover MRSA as well as meningococcemia as well as scrub. I mean, this is a sick child, so we don't have not much time. I mean, if there was features to suggest actually toxic shock syndrome, which I don't think it is because the illness was actually protracted. Maybe we could have added clindamycin, but otherwise I think it's vanco, ceftriaxone, doxy would have been the most appropriate. Yeah.
Dr. Winsley, Professor PRC has a very specific question. You repeatedly said the spotted fever IgM. Can you elaborate on that test? We have not asked for it. We do not know what it is. Can you please elaborate?
So spotted fever IgM. So it's actually so the thing is, spotted fever rickettsiosis is about 1/10 of all rickettsial infections that we see. I mean, if you see scrub typhus 10 times, one of them, one time you'll see spotted fever. It's actually, that's the kind of the frequency that you see it. And what the exact causes of this spotted fever is not very clear. Around Vellore, we've got a spotted fever which is caused by a Rickettsia kellii. That's the species which causes spotted fever around Vellore, but it may be slightly different species in other parts of the country. Now, the test which is done is actually a spotted fever IgM, which actually uses the Rickettsia conoriae antigen as the antigen for which we are detecting antibodies. And that is a good test to actually diagnose spotted fever, whether it was kellii or even conoriae. I mean, that's a good test. So I'm not sure what the commercial assay that's available is. I mean, in our own lab, we actually do a spotted fever IgM, which I think is from a commercial assay only. And it uses the Rickettsia conoriae antigen. Yeah.
Yeah, thank you so much. Are we ready to load case number 3?
What do you do in Ashwath in Coimbatore? Whether spotted fever IgM is available?
No, I have not heard of it. That's why I was keen, because Dr. Ramchandran also raised the same query. We usually give Velflix and hope for a positive result. Usually patient is afebrile before the results are available.
No, there is a panel. Spotted fever IgM is possibly done in Coimbatore. And I have had instances of spotted fever. As Dr. Winsley said, it is not as very common as scrub typhus, but definitely spotted fever does exist.
Yes, there is a panel which is available, fever panel. Which,
it is available.
Yeah, it's available.
Can we have case number 3, Dr. Divya?
Yeah, so please don't pause let them start loading. I mean,
Dr.
just to know.
Thirumurugan. Please.
Hello. Yeah, I just joined.
Yeah, third case, please.
Yeah. So while that's loading, so Velflix test. So that's another good test if it comes positive, because the Velflix test actually has 3 antigens, like 3 protease antigen. You have OX2, OX19, and OXK. OX2 and 19 can be positive for spotted fever rickettsiosis, whereas OXK is specific for scrub typhus. But the trouble with the test is it's only 35% sensitive. Specificity, if you take a positivity of more than 80, it may be close to 100% specificity. But sensitivity is very, very poor. So even if you find a negative Velflix, I mean, you'll still have to look for another. It could still be the same disease. Yeah.
Thank you.
Sorry, which is the next case?
No, you can present. All the presenters are here.
Okay, fine. So I have got one on this thing. Just 1 second. Yeah.
This is Dr. Janaranjani from Dharmapuri Medical College, I think, under the guidance of Dr. Balaji. Is Dr. Janaranjani here?
Yes, sir. Can you hear me, sir?
Please go
Yes,
for
very well heard. Proceed.
Slide sharing mode, please.
Divya, just go to F5, press F5. F5. So just 1 second, sir. Otherwise, I'll just start. Just give me 1 second.
Janaranjani, it's not audible. Janaranjani, please check your audio and video.
Sir, can you hear me, sir?
Yeah.
Sorry, I'll just present change another case. Just give me for 1 second. Nandini Kumaran, madam.
Yes, ma'am.
Nandini Madam, please.
Yeah. Good evening. After these two interesting cases, which gave opportunities for the leading panelists to really think, mine is a very, very simple case. The fever with rash. Yes, next slide. This is a 5-year-old girl who came to with the 2 days of fever. They had noticed the rash on day 2. And then she had vomited 1 or 2 times, and then she did complain of throat pain. There was a decreased oral intake. The fever details were it was an abrupt onset of fever, and the family was traveling. It was out of town, and the fever range was moderate, which was about 102. And it did respond to paracetamol, but to recur within 4 to 6 hours. So they had used almost 4 to 5 doses of paracetamol in the previous 24 hours. They did not seek any medical attention as they wanted to come to Coimbatore and then see their pediatrician. And then the next day morning, they noticed the rash. This rash was seen in the trunk, that is the neck and the trunk. She did vomit a time, 1 or 2 times, just the ingested food. She did complain of throat pain. Her oral intake was less and she started appearing tired. It was at this stage of day 2 of fever that the child was brought over to the clinic. Next. So she was febrile, about 102. Her vitals as stated about tachycardia. And then the respiratory rate was within the normal. Her saturations were normal. Her CRT was 22 seconds with a blood pressure of 90/60. And if you take her anthropometry, she was almost between the 50th and the 75th centile for the weight and the height. And the BMI was a little above the 50th centile. And the description of the rashes were diffuse, erythematous. They were more maculopapular. They were little reddish. They were branching on pressure. Sorry for the spelling mistake. The rashes had a sandpaper feel on touch. And the main distribution of the rashes was in the neck and in the trunk and some part of the upper limbs. The palms were spared. In fact, the rashes were less in the lower limbs. And if you had a look at the visible part of the mucosa, like the lips and the conjunctiva, they were all normal. Next. Next. So this was the rash, which was seen in the neck and in the chest. It was erythematous with the brown Indian skin. Sometimes you can see the rash, and then sometimes the rashes become better after you touch and blanch. And then you can also see that the rashes gave a sort of a sandpaper appearance. More than that, the feel was much more. Next. And examination of the oropharynx, the tongue was coated and it had prominent papillae, an appearance of a white strawberry tongue. The tonsils in the oropharynx were swollen and congested. They did not show any exudates or follicles, and there were bilateral tender anterior cervical nodes. There were no other significant cervical nodes or any other generalized nodes, and the evaluation of the abdomen did not show any hepatosplenomegaly. The rest of the examination of the cardiovascular and the respiratory systems were normal. So this was a school-going 5-year-old child, abrupt onset of fever, reporting on day 2. And even on day 2 itself, the rashes were seen, and the description of the rashes are there, and you had some findings in the throat. So with this, should I stop?
No, ma'am, you can give us your differences. We can take the differences.
Next. This was the tongue, where you could see some coating, and then you could see still the papillae, which were looking
white
prominent. Yes. Next. And so with this presentation, at least immediately, I did consider straight away the group A streptococcal infection, the gas infection. The diagnosis is more clinical because of the abrupt onset of fever, and the rash onset within 24 to 48 hours of the onset of the fever. Because most of the virals, as I'll discuss with you, so I did do a rapid antigen detection test, took a throat swab, and then the streptococcal A test was done. Yes. Next. You can click, you'll get the click. The test was positive. No, yeah. The test was positive. This is the test. Yeah, please go on to the previous slide. This is a test which is just you touch a swab and then you add it to a reagent, and then there's a strip of paper, and then you that is the reagent is mixed, and then the paper is just it is just dipped into that reagent which has been added after the swab is being put into the reagent. Within 5 to 10 minutes, you will get the control and the test line, and it just takes only 10 minutes. And the cost of this kit is about 300 rupees. So this is a very rapid, really group A streptococcal antigen detection kit. And the sensitivity of this is about 80 to 90%. And the test was positive in this child. Next. The differentials, though, the closest, we always consider Kawasaki disease, other viral exanthems, and other acute viral pharyngitis. And, in Kawasaki disease, children sometimes can be even younger. But if you take a scarlet, they're never younger than 2 or 3 years. They're usually the commonest age group for a streptococcal throat is usually about 3. The Kawasaki disease children are sometimes even younger. And Kawasaki goes through a thing like you will not have all the system involvement in one. It is a constellation of symptoms. It starts with one and then progresses to another. Like on day 1, there can be fever, just fever can continue. Then day 2, your eyes can appear red. Over here, we did not have any changes. It was only a very short because the presentation is on day 2. We did not make out any thing in the eyes, nor in the, that is at least the mucosa, lips, etc. Though we had findings in the throat. More than that, the nodes were bilateral and they were tender. So Kawasaki is usually bilateral or unilateral, usually not tender. You have findings in the conjunctiva and the periphery, at least the hands and the feet, there was no erythema, there was no swelling. And so that gives more, less likely of Kawasaki. Other viral exanthems, like if you say exanthems associated with virus, do not start on day 2. Little unusual to start within 24 to 48 hours. Even if you take dengue or if you take other viral exanthems, everything, the rash starts a little later only, almost the 4th day, 5th day, etc. Other acute viral pharyngitis, they do have some, that is more than the throat mucosa being involved. They have symptoms of either little cold or a stuffy nose, or they may have a little dry cough. They do complain of throat pain, but then they do have eye and nasal congestion. So the mucosal involvement is a little more than only the throat. Whereas in streptococcal, you do not get any other mucosa. It is just only the throat that is involved. Your eyes are normal, your nose, everything is perfectly normal. None of the other mucosa are congested or red. And that's how Isaac or modified center scoring came, where there are about 5 points. And if you get 4 out of 5, then the chances of the throat being the streptococcal tonsillopharyngitis is much more. This has come because we do not want to miss streptococcal infection and treat them, because a percentage of children do go in for acute rheumatic fever. For that sake, this has come. But if you take the points like a temperature more than 38 degrees centigrade, that is 100.4 degrees Fahrenheit, and if you have no cough, and you have tender cervical nodes, and you have a tonsillar swelling with exudates, and the age group for this is in the age group of 3 to 14 years, that each of these points, each of them are given a score, and a score of anything more than 4, or sometimes it can even be 5. Even then they say the problem with the scoring is even when it is 4 or positive out of 5, then the chances of a streptococcal infection is only about 60%. So these scores are little okay just for us to say, because if you don't have cough or you have cough and then you have general other mucosa involved, you'd swing the pendulum more towards a virus. So that is how it helps, so that we exclude the streptococcal infection. So this child, I think the other DDs do not come into picture. This looked like straight away like a scarlet fever. The diagnosis was mainly clinical, but I have the habit of doing the streptococcal test. That is how it has come. And the treatment is very simple. As we do not have oral penicillin, it is always amoxicillin in a dose of 50 milligram per kg per day in 2 divided doses. And it has to be explained, it has to be taken for 10 days. The maximum dose milligram per dose is 500, and you always give it only 2 times a day. Therefore, do not exceed 1 gram per day. And in this child, when amoxicillin was started, I did not admit the child. It's an outpatient treatment. Amoxicillin was started along with hydrating the child with fluids and also giving paracetamol for the fever. And they were asked to come within 24 hours. And the fever was just after 1 or 2 doses of amoxicillin. There's no fever. That's all. It is something like what you get in rickettsial, like tuck, 24 hours, after the onset of the antibiotic, you get a response. It is almost like the fever just drops down like a crisis sort of a thing. And then when they came over the next day, the rashes were there because, as you know, the diagnosis of scarlet fever, this is a group A streptococcal infection. And this particular streptococcus produces an erythrogenic or a pyrogenic toxin, exotoxin. And if an individual does not have antibodies to this antitoxin antibodies, these are the individuals who go in for scarlet fever. So when they come a day or 2 later, the white coat goes away and then your papillas stand out prominently. So the white strawberry becomes a real strawberry. And this is also followed by desquamation of the skin. The desquamation is something like a sunburn desquamation. And this is the picture of the sunburn desquamation. You can get a desquamation mimicking Kawasaki, like the periungual. You can also get desquamation of the palms and the soles and sheaths also. But only thing we know with Kawasaki, the desquamation is only in the 2nd to 3rd week, never in the first few days or within the first week of illness. Thank you for the opportunity. This case is a very simple one in comparison to breaking the brain like the previous 2 presentations. Thank you.
Thank you, ma'am. Thank you for sharing a very classical presentation of scarlet fever. We can move on to the next case with just a quick word from Professor Winsley. Would you consider anything at all, or is this classic enough to just go ahead and treat without doing the streptococcal antigen? Is there any medical legal implication to not knowing doing this? Is there a threat of rheumatic fever after scarlet fever? These are the queries.
So I think scarlet fever is a clinical diagnosis, and this is very classical for scarlet fever. If I can, I mean, I don't know, like there was one mnemonic we all used to learn. It's like, it's to say certain silly, I don't know, there are many versions of this mnemonic. We called it certain silly people mistake typhus for typhoid. So, and that certain was chickenpox, the second, the S was scarlet fever. So I think this is very classical. I wouldn't necessarily do a test to diagnose scarlet fever.
Is there a threat of rheumatic fever following this?
Yes, definitely. I mean, in fact, it's one of the, if you look at the essential criteria for diagnosing rheumatic fever, scarlet fever is actually, history of scarlet fever is one of them.
Perfect. Thank you so much. Can we go, due to shortage of time and truncating the discussion, can we have the next presentation? The previous slide, please. I do not know who's presenting.
Good evening, sir.
Yeah, Vidya.
Dr. Vidya
yes,
from Madurai.
Yes, sir. I'm Dr. Can I start, sir?
Yes, ma'am, please.
Yes,
go ahead.
No, sorry,
yes,
can I just
Dr.
hold on? I think there is a problem in the other system. Just give me 1 second. We might have to choose some other. Yeah, I'll just put it out. Just 1 second. I'll just
Well,
do it.
before getting sorted or out, as a practitioner, after life-threatening rashes, that is already we have told, like meningococcal or toxic shock syndrome and anything. Next goes for the organ-threatening rashes. Organ-threatening comes, that is cardiac organ, mainly two things. One is scarlet fever. The nearest DD is Kawasaki disease. This scarlet fever and Kawasaki disease already Madam has clearly enumerated. Kawasaki less than 5 years and the scarlet is above 5 years. And all the clinical features Madam has told. Coming to the CBC, in scarlet, you will have eosinophilia. That is one good feature. Neutrophilia with eosinophilia with normal platelets. Whereas in case of KD, you will have a neutrophilia with thrombocytosis and with high markedly elevated ESR and CRP. These are the extra features which can be useful for a practitioner.
Thank you. Thank you, Dr. Paniraman. Can we have the presentation from Dr. Vidya, please?
Yes, sir. I'm Dr. Vidya,
Can you see the full
pediatric
screen?
resident.
Sorry, is the full screen visible?
Yeah, visible, please proceed.
Yes, Dr. Sarup. Okay.
Can I start, sir?
Yes.
Please.
Good evening, sir. I'm Dr. Vidya, pediatric resident from Institute of Child Health and Research Center, Madurai, sir. Thank you for giving this opportunity. I'm presenting this case under the guidance of Dr. Balashankar, sir, who's our director. So without further ado, we present a case of 15-month-old boy who's developmentally normal and appropriately immunized child. He was referred from Virudhunagar Medical College with complaints of fever for 12 days, which was high grade and a continuous fever. And he presented with rash from day 2 of fever, which started as red macules over the trunk and progressed all over the body and changed to dark colored crusted papules after 7 days. And we received the child after 7 days of his illness. And he also had symptoms of irritability and decreased oral intake for 7 days, along with bilateral swelling of the legs, which was present for the past 4 days. Can I have the next slide, please? And to rule out drug-induced fever, there was no history of itching, and there was no history of any joint pain or swelling, and there was no periorbital puffiness, swelling of the hands, or any abdomen distension, and there was no discharge from the eyes, and there were no enanthem oral ulcers, and no other bleeding manifestations, and there was no history of fast breathing, cough, and no known history of drug allergy, recent travel, contact history with sick patient, or pet or animal exposure. Can I have the next slide? And on examination, the child was febrile, toxic, irritable, and he was able to take oral feeds. He had a relative tachycardia for his age, and his respiratory rate was normal. His circulation and peripheral pulses were within normal limits. The child had a mild pallor and bilateral non-pitting pedal edema, which was present up to the ankles. And there was no icterus clubbing or lymphadenopathy. His eyes and oral cavity were normal. There were no enanthems. Per abdomen examination findings were normal, and his external genitalia was normal. No desquamation or rashes over there, and other systems were within normal limits. So describing the rash, there were multiple well to ill-defined, non-palpable, non-blanching purpuric rashes, which were 0.3 to 0.5 centimeters to about 0.5 to 1 centimeter over the chest, abdomen, back, both the upper and lower limbs. There were also purpuric macules over both the palms and soles, and they were also non-blanchable. There were multiple crusted plaques, about 0.5 to 0.5 centimeters, with peripheral collaret of scales over both the arms. Oral and ocular mucosa was normal. There was no ulceration or discharge. The BCG scar site was present, and there was no reactivation. Coming to the lab investigations, we can have the next one. Coming to the lab investigations, the investigations done in the first week of illness on day 5 showed relative anemia for his age with normal counts and normal platelet with a highly elevated ESR of about 120 and CRP was 35. In the second week of illness during day 11, the child had fallen HB and highly elevated platelets more than 7 lakhs, and his ESR remained high and CRP had elevated to up to 104. His coagulation profile, liver function test and renal function test were normal. He had about mild hyponatremia, and he had a relative hypoalbuminemia as well. His albumin level was 3.4, and the previous slide. Yeah. So since the child was about 1 year old, we also wanted to rule out other causes of non-infectious causes of fever with rash. And so we had done an ANA, ASO titer and RA factor, which turned out to be negative. His complement levels were within normal limits. The peripheral smear revealed a hypochromic microcytic anemia with relative leukocytosis and thrombocytosis. And his urine analysis was normal. We wanted to look for hematuria and proteinuria, which were negative. And the chest X-ray had a normal study. Due to his features, we wanted to rule out atypical Kawasaki disease, and hence we had taken ECG and an echo. In the ECG, we just could find a sinus tachycardia with normal axis, and we had a doubtful inverted T waves in V4, V5, and V6 leads. On the echo, we got a diameter of the right coronary artery as 2.2 mm with a Z-score of 3.17. That is more than 2.5, which is significantly dilated. And the left coronary artery main branch was about 2.7 mm, which was also dilated. Can we have the next slide, please? Coming to the differentials, our first differential was a Kawasaki disease. The points which were for it were the child's age. First thing, he was less than 5-year-old, fever for more than 5 days. There was a polymorphous rash with pedal edema, and the child was irritable, having aseptic meningitis-like symptoms, but no meningeal signs on examination. There was leukocytosis, significant thrombocytosis after the first week of illness, elevated inflammation markers with ESR and CRP touching about 100, and coronary arteries were dilated. And towards the end, we'll show a picture where the rash is healed with typical desquamation. The points which we had against was that there was no non-exudative conjunctivitis, no enanthems, and no cervical lymphadenopathy. And when we treated the child with IVIG, he remained febrile even after 24 hours of completion of IVIG. So other DDs we had were MASE, multi-system inflammatory multi-system of children, and which is post-COVID, and which presents with fever, rash, and elevated inflammatory markers in the post-COVID period. But against points were that the child had a negative COVID antibody and others like above, and there were no systemic decompensation in the involvement of other systems. The third DD was scarlet fever, which the points were the fever and the rash on day 2 of illness, but against points were that the pharynx was normal and there was no response to antibiotics, and also we did not do a RADT, we did a ASO titer, it was negative. Other DDs were adenoviral infection and other viral causes which also present with fever and rash, but usually it is associated with the exudative pharyngitis and conjunctivitis, which is not so in our case. The rickettsial spotted fever group was also suspected because of the fever and high grade in nature, and along with this purpuric rash. And when we went through the literature, we were able to find some cases of small vessel vasculitis like leukocytoclastic vasculitis and even purpura fulminans, which were attributed to spotted fever group. And so we had put the child on empirical doxycycline, and the child did respond to doxycycline. So we had a doubt of rickettsial spotted fever group. But the points
Dr.
against were that there was... Yes, sir?
Yeah, sorry, ma. We just wanted to take a small break here and ask Professor Satish for his comment.
Sure,
we
sir.
have a child with macropapilla rash, which became crusted, and we have edema, we have raised inflammatory. Can you go back to the investigations, please? The investigations. Yeah, investigations. Dr. Satish, your inputs, your comments. Do we have to think beyond incomplete Kawasaki disease? Do we have to go through so many DDs, or would you be convinced with the diagnosis? Can you interpret this slide for us?
So correct. So this child has got fulfills the criteria for incomplete Kawasaki disease. So we no need to have eye congestion, cervical lymph nodes. So any 2 or 3 features of the 5: non-prone conjunctivitis, oral changes, nodes, rash, and edema. This child had classical edema, rash. Regarding rash in Kawasaki disease, you can describe any type of rash: maculopapular, purpuric, faint rash. Any type of rash is described in Kawasaki disease. So, and this edema is very predominant, and this child has got typical irritability in the clinical thing. So my suggestion will be, first things to consider incomplete Kawasaki disease, and you evaluate. So I don't think this child needs ANA, C3, C4. Rheumatoid factor should not have been done for this child because this child never had arthritis. Even if rheumatoid factor comes positive, I'm not going to heart association. So if you have less than 4 clinical symptoms of Kawasaki disease, then you go by ESR CRP. If the ESR and CRP is high, you do anemia, platelet count, especially on second week, more than 4.5 lakhs, albumin less than 3, elevated ALT level, WBC count more than 15,000, and sterile pyuria. Your child automatically fulfills criteria for incomplete Kawasaki disease. So I would have done an echo. Whether waiting for the echo, I will give IVIG even before the echo, because no other differential diagnosis will have this clinical presentation and this platelets of 7,66,000. Our whole aim of treating Kawasaki disease is to prevent that coronary artery aneurysm. So don't wait for the echo. Echo can be done tomorrow, day after tomorrow. With this preliminary lab test and the clinical scenario, I think IVIG should be given as soon as possible.
And a quick pointer, are all dilated coronaries either MIS-C or Kawasaki, or should the clinician keep other vasculitic disorders also in mind?
Yeah. So so nowadays, remember this MIS-C, I think we all should forget. All the pediatricians should forget MIS-C now, because the antibody is going to be positive. Luckily, I don't know how your child antibody was negative. Almost every child is going to have antibody positivity. Based on the antibody positivity, whether you call MIS-C or Kawasaki disease, the clinical phenotype is very, very important than labeling them as MIS-C or Kawasaki disease. MIS-C also present like Kawasaki disease. How different is the treatment? The treatment is going to be same, IVIG only. So don't worry about the COVID antibody and the MIS-C diagnosis.
Dr. Vidya, thanks for that excellent slide, and Dr. Satish, thanks so much for being patient with this particular slide, because
Thank you, sir.
this is what every clinician will go through. Can you wrap up the case fast, ma?
Yes,
So
sir.
you can proceed with your findings. You can close the
Sure.
case and tell us what you did with the child and what the final diagnosis was.
Yes, sir. We started the child immediately on IVIG, and first line we started the child on ceftriaxone as well, sir. And after IVIG, 24 hours had completed and the child still remained febrile. We wanted to wait for another 12 hours, since we can wait till 36 hours for the child to turn afebrile after IVIG, because about 10% of cases can have a delayed response. But still, since there was some small vessel vasculitis-like presentation in the child, and there was a high-grade fever, we wanted to give a trial of doxycycline because of the epidemiological reasons. And the child did turn afebrile after about 36 hours of completion of IVIG, sir. And the thing is that the child initially had an echo of a normal study, and then when we rechecked, it was the coronaries were dilated, sir. So there was some little confusion in that part. But since the algorithm is showing positive, it is taken as incomplete Kawasaki disease only, sir. What we had doubt is that whether, because Kawasaki is usually triggered by infections, could rickettsial infections also trigger Kawasaki? Is it a possibility, sir?
Yeah, so Kawasaki disease is a hyperimmune system or super antigen disease. So any infection can precipitate a Kawasaki disease. So you treat the underlying disease, but you treat the Kawasaki disease also. The other thing is, you talked about IVIG resistance. So IVIG resistance, according to definition, is 36 hours after giving completion of IVIG, not starting. You wait up to the completion of IVIG, 36 hours. The fever is persisting. You consider IVIG resistant Kawasaki disease. Then we have algorithms to how to deal with, whether to give steroids, whether to give IVIG, or whether to give infliximab. And leukocytoclastic vasculitis, you said in biopsy, which is also well reported in Kawasaki children. That's why we don't go for biopsy unnecessarily. It's not going to change. So we don't go for biopsy. Report will take 1 week to come, all those things. So we don't do biopsy for a Kawasaki disease. So this fits into incomplete Kawasaki disease, so coronary artery aneurysm. This
Thanks for a superb presentation and a superb analysis, Dr. Satish. Thank you. Thank you so much. Thanks for that very elegant presentation, Dr. Vidya. Can we go on to the next slide, please? Next presentation. We are running out of time. We are supposed to finish by 9:30.
Sir?
I think there's so many inputs that are coming.
Sir, any input from Professor Balashankar?
Sir, only one small this, sir. Sir, how far this rash in palms and sole is common in Kawasaki, sir?
So that's why I was telling you, sir, when we first case also we discussed, when you have palms and soles rash, you think of infection. We talked about rickettsial, and in Kawasaki disease, palms and soles are classically involved with this edema. Rash is very classically seen in Kawasaki disease.
This child had some round rashes. Actually, it was not erythematous or anything. So that's what we suspected rickettsial infection in this child. And then only we gave doxycycline and it responded the next day. We do not know whether it took some time for the IVIG to act or it responded to doxy. So but the literature also showed that this can cause vasculitis like a picture, rickettsial disease.
Yes.
Similar vasculitis can occur. That's what doubt we had. But coronary dilatation was there. Sir,
Yes.
do you get coronary dilatation in any other vasculitis, sir? That's one another doubt.
No, sir. No, sir. Kawasaki is the one thing which we have the typical, because this is almost more than 3. Mild coronary artery dilatation can be seen in any viral infection. But this is almost 3. Around 2 to 2.5, if the Z scores are there, we can think of some other viral infection or any infection. But anything more than 2.5 Z score, we should consider only KD.
Thank you, sir.
Otherwise proven.
Thank you.
Thank you. Can we quickly move
sir,
on
if
to
you
the
actually-
next case?
Sorry, if I can just interject, that rash actually looks very typical for a spotted fever rickettsiosis. The rash involving the sole looks very much like spotted fever rickettsiosis, but all the other investigations are all favoring Kawasaki. But so again, like if you had done spotted fever IgM, that's a good, I mean, you might have had a better listing of the diagnosis. Sorry.
Okay.
Thank you.
Thank you.
We'll wrap up that case, and now I invite Dr. Kritika, Associate Professor of Pediatrics, Young and Dynamic Pediatrician from Teni Medical College, to present her case. Over to you, ma'am.
Thank you, sir. Respected IAP TNSC office bearers, present, past, and elect, and IAP TNSC Academy Coordinator, Convener, and team, respected seniors and dear friends. Good evening, and thank you so much for the opportunity. I'm Kritika, practicing pediatrician in Virudhunagar. This presentation is about a 6-year-old male child who presented on 5th day of fever to us, who had cough. This is preceding fever for 1 day. Cough was for 6 days, which was usually dry, sometimes wet, which did not disturb any of the child's routine activities. And fever lasted for 5 days. It was high grade and responded to paracetamol. The fever was on decreasing trend when he presented to us. On interfebrile period, the child was not usual. That was the thing reported by the mother. The child is not usually interacting and not taking the feeds as usual. The child had eye discharge for 4 days, but the child had been treated in a tertiary ophthalmic hospital for allergic rhinitis for 2 months. He had his last discharge before 2 weeks of presentation. At present, he is having 4 days, but mother said this is not the usual eye discharge that he had in the previous time. He's not rubbing his eyes, and this is purulent and bilateral this time. And he had cracked lip and oral ulcers for 4 days. Next slide, please. And drugs given, the child had been treated with only 2 doses of amoxicillin for enlarged tonsils with white follicles in the throat, and also for odinophagia only in the initial 2 days. As the child developed some oral lesions, and it was stopped, and only paracetamol was given for the fever. And there was no significant illness in the past, and the child had not been admitted in the hospital previously, and the child had been given so many doses of amoxicillin, cephalosporins, and macrolides in the past for various URI infections and UTI episodes, and no untoward events were noted at the time also. And he was a second-born child to the 3rd-degree consanguineous married parent, and no similar illness in the family. And regarding immunization, he was up to date. Next slide, please. Next slide, please. And these are the clinical findings we can see. Except those small crusts which are noticed under the nose, he did not have any other skin lesions. And I think we can see that oral crusts. The child had so many crusting ulcers over the lips, in the hard palate, over the buccal mucosa, and in the tongue. And also he had bilateral purulent conjunctivitis. And other clinic, and he also had bilateral cervical lymphadenopathy, which was significant. And its anthropometry was normal for age and gender. And vital signs, he had tachycardia and respiratory system. He had cough with the scattered crusts here and there. His tonsils were enlarged with some white follicles, which were not erythematous. He was, his saturation was 98% in room air. And he was febrile with 101.3 degree Fahrenheit on admission, and later became normal. Abdomen was soft without any organomegaly, and a cardiovascular and central nervous system were clinically normal. So differential diagnoses that are considered on admission were, could it be drug reactions like Stevens-Johnson syndrome, or DRESS, that is drug rashes, eosinophilia with systemic symptoms, Or could it be MIRM, mycoplasma-induced rash with mucositis? Or could it be systemic lupus erythematosus? Or could it be Kawasaki disease or MIS-C? But the child became afebrile on the evening of admission, that is on the day 5 of fever. So I have not posted any investigations as the template provided did not allow investigations. So I think we can discuss it one by one in narrowing down the differential diagnosis. Regarding drug reaction as the possibility of as a diagnosis, in case of Stevens-Johnson syndrome, there will be extensive skin lesions that involve 10 to 30% of this cutaneous area. And here it is not so, and there is no desquamation, and child is not sick and not febrile on day 6. And his transaminases were normal and RFT was normal. There were no systemic symptoms. And his CBC white blood cell count was 8,500 with polymorphs predominating it with 63%. Only 3% were eosinophils. And there was no eosinophilia also. And also the suspected drug that amoxicillin was stopped on day 1 itself, but the oral and the lip lesions continue to worsen. Could it be mycoplasma-induced rash and mucositis? We shall discuss it later. Next slide. Next, please. The systemic lupus erythematosus. So though there are no classical other things concerned with the systemic lupus erythematosus and fever subsided on day 1, this SLE is known to evolve at the later, evolve day by day. And so we did not want to miss this sinister diagnosis, and we did complement. The complement C3 and C4 were normal, and ANA turned out to be weakly positive, but the pattern was nucleoplasm fine granular, and the laboratory provided it as a weak positive titer with 1:100. Next, please.
Dr. Kritika, can we just stop here and take a pause, please?
Yes, sir. Yes, sir.
Yeah. Dr. Kalyan Paniramanna, can you please tell the clinician when we have to worry? I mean, when this child has come with fever, conjunctivitis, oral lesions, 99 out of 100 times, this will be some undifferentiated viral illness. What are the red flags when a child comes with conjunctival and oral mucocutaneous changes other than Kawasaki? When should the pediatrician have his antennae all out?
When a pediatrician has particularly the more than 2 mucosa involved, like this in this case, like conjunctival rash as well as oral mucosal rash or genital rash, we should always look for the skin reaction. If there is a generalized skin reaction, our antenna should be high always to rule out SJS, Stevens-Johnson syndrome should be the first in our mind always. Or sometimes you can look for the target lesions. Target lesions like it will be like a target lesion. Only we can't, unless we show, we can't say how to describe this. Description is very difficult. When you have a target lesion with 1 or 2 mucosa, we can say it is mostly a erythema multiforme. And that is the second thing. And the third thing, when there is a mucositis like this, and we always think about like herpes simplex, like gingival stomatitis, but usually the conjunctiva will be spared. Usually you will have only the oral mucositis and oral ulcerations here and there, but there will be won't be confluent. They will be scattered as time goes on. So only these things I will consider. I will always want to rule out, am I dealing with the erythema multiforme major or a Stevens-Johnson syndrome? Usually erythema multiforme is infection induced, whereas Stevens-Johnson is usually drug induced. These are the 2 important things I want to rule out in this case.
Dr. Kritika very pointedly made out a point to say that this is unlike to SJS because she stopped the offending or the likely offending drug on day 1 and yet the rash continued to progress. Would you agree with that point? I mean, does stopping the drug on day 1 stop the progression of SJS?
Definitely not, because after 2 days also you can start and it can progress, because it is an immune mediated rash. So it is not related to the dose dependent on other things. So you can definitely, stopping the drug does not mean that it will completely stop the quick progression of the thing. If you're already exposed and already getting immune sensitized, not in the first episode. First episode may take some time, but for the second repeated exposure, no need for the thing to take time.
Dr. Winsley, your comment?
Clearly close, particularly with the cough and everything, clearly goes for MIRM only in this case.
Dr. Winsley, your comments on this
pattern of blistering
lesion of the lips?
I agree with Dr. Palindram all this. I mean, DDs. I think it's. I also would have thought first was SJS, and but anyway, the next would definitely be mycoplasma. Herpes simplex again can cause gingival stomatitis, which looks, which can look very bad, but there is no eye involvement. So here the eye involvement makes it more like SJS or mycoplasma-induced rash.
The child has got respiratory findings with crackles and a dry hacking cough. Would that be a pointer?
All that I think makes it more likely to be mycoplasma. But then SJS, I mean, it's a drug-induced thing. So just because a child has respiratory infection and you give an antibiotic and then develops this thing, you cannot necessarily say that sort of rules out an SJS. So yeah, that's.
Okay. Thank you. Dr. Kritika, can you just rapidly go through
Yes,
the case scenario and
Yes,
tell us how it unfolded? Thank you.
Yes, sir.
Yeah,
Next slide,
Ashwath,
please,
I
sir.
just want to make one comment. This the ruling out SLE, I don't think this child has got SLE. The ruling out SLE, we should do only ANA from a general pediatrician point of view. Leave the C3, C4 to the rheumatologist, because C3, C4 will be low if you have a lupus nephritis. If they have only rash, fever, arthritis, C3, C4 will be normal. And remember that C3, C4 is the costliest test. I don't know about outside. In CMC, it costs about 1,800 rupees to do C3, C4. Again, ANA, check with the lab how they are doing. I saw this one is done by the indirect immunofluorescence, and we always take it 1 in 160 as positive.
Yes,
This
sir.
one, they are given the dilution of 1 in 100. So if you suspect SLE in a clinic, in a general practice, always do only ANA and urine routine to look for protein. Don't do C3, C4 or dsDNA, or don't order ANA profile in your practice. Thank you.
Well taken, sir.
Thank you.
ANA by which method, boss? Which method?
Immunofluorescence.
Indirect immunofluorescence. Okay. Yeah.
The next slide, sir. So the final diagnosis was MIRM, mycoplasma-induced rash and mucositis. There is a criteria to diagnose MIRM. Next click. So there is a skin detachment, if at all, will be present in less than 10% of the body surface area, and there will be more than or equal to 2 mucosal sites involved. Here, eye is involved and oral mucosa is involved, and few vesiculobullous lesions or target lesions may be noted. And here we did not have any skin lesions and no target-eyed lesions were present. And evidence of atypical pneumonia. Clinical, there was fever, cough, and positive auscultatory findings, but X-ray was normal. And laboratory, we didn't do that because it was not available in our place, and also it was very costly for the for family. And regarding PCR, in case of MIRM, PCR may be positive even for up to 4 months, and it will not be of a diagnostic yield. And regarding the IgM antibodies, it will start rising only after the 9th day of illness, and IgG will be rising after 2 weeks of IgM positivity. But it was not done in this case. And the child was started on, next click, sir, doxycycline along with chlorhexidine mouthwash and saline gauze application and saline drops application to the eye. Next click, sir. And this is a child. The child started healing beautifully from the day 2 of starting doxycycline, and he really looked very well. Thank you so much for the opportunity, sir.
Any particular reason you did not use the azithromycin and prefer to use doxycycline?
The child had been treated with azithromycin for so many times, sir. So I was worried about the resistance, and I started on doxycycline, sir.
Yes, mycoplasma known to be resistant to azithromycin. Macrolide resistance and mycoplasma, Professor Winsley?
Yes, sir. Yes, sir. It has been reported. Yes.
Winsley, boss.
Yeah, I think we can't culture mycoplasma, so it's actually difficult to phenotypic testing. So there is mycoplasma, I mean, resistance to macrolides reported in mycoplasma. So, but we really can't say what percentage or whatever, because none of us do it here because it has to be a genetic test.
What would be the second drug of choice?
Quinolones will work, doxycycline will work.
Thank you so much. Can we move on quickly to case number 5? Next case. Thanks, Dr. Kritika, for the very elegant and sweet presentation.
Thank you, sir.
The same type, actually, I had a lesion with the target lesion with the same oral picture and turned out to be herpes simplex, secondary to herpes simplex.
Next case presentation, please.
Dr. Thuru, please.
Yeah. Over to Dr. Sendil, young and dynamic pediatrician from the periphery suburbs of Coimbatore. Over to you, Dr. Sendil. Be very brief and be to the point.
Sure, sir. Thank you, sir, for this opportunity. Hello, am I audible, sir?
Yes.
Yes, yes. Please.
Thank you. I received a 11-year boy with 10 days fever, which is intermittent and type, And the rash started on day 4 of illness. For the last 7 days, he was having skin rash. And he also had pain in both the knees, ankle, and abdomen for the last 5 days. The illness is associated with cough, vomiting, and tiredness. There was no history of bleeding, altered sensorium, breathlessness, or abdominal distension. There is no similar illness in the past, and no family members were affected recently. He was admitted in a nearby hospital for the last 4 days, where he received ceftriaxone, azithromycin, dexamethasone, and diclofenac injection. Next slide. So on examination, his vital parameters and anthropometry were normal. The skin, he had palpable purpura over bilateral upper and lower limbs, palms, sole of foot, trunk, and face. Almost all the parts of the body were involved. His cardiovascular system, ORS, and CNS was normal. His abdominal examination showed soft, non-distended, and there is diffuse tenderness without rigidity or guarding. There is no organomegaly. Next slide. This slide shows palpable purpura in both the legs. I am not sure this slide is so clear, but this is palpable purpura, which is not blanchable, seen both in the palms and soles. So this is a tick which I was able to take it out from the popliteal fossa of his leg. And on asking him again, they were having pet animals, both cat and dog at the home. So now, next slide. From a practicing pediatrician, I received this child who has received ceftriaxone, azithromycin for the past 4 days. And my first differential, it's a clear-cut case of rickettsial fever. Dengue was ruled out because previous hospital did investigation, which was negative for dengue serology, and he didn't have any thrombocytopenia. Malaria, typhus, and bacterial infection was ruled out with a negative blood culture report. So I just wanted to say, without fever, if the case has presented to us, the close differential diagnosis would be a HSP, where the rash, joint pain, and pain abdomen would be a major clinical finding. Here, since I had a fever, rash, history of pet animals in the family, and a tick noted in the body, I was able to find out it is a rickettsial infection. I have
Can
ruled
we just stop here, Dr. Sandal, briefly?
Yes, sir.
Yeah. Professor Winsley, would the involvement of the palmoplantar area be a very useful pointer in distinguish which type of differentials to consider? Is that very typical of rickettsia? Yes, but is it specific to rickettsia?
So, I mean, if you think about what else can cause involvement of the palms and soles, but the way this rash was, that papular rash, which involves the palms and soles, that's very, very typical for a rickettsial spotted fever. So the other rashes which involve the palms and soles would be, hand, foot, and mouth disease. But again, then again, it's a vesicular rash. You'll have something in the throat as well. So the other thing is maybe parvovirus B19. Where they have a rash which involves, which has a sort of a glove and stocking appearance. They might have some anemia associated with it. But then the fever also goes on for a longish duration. So other than that, Kawasaki, of course, can involve the palms and soles. But this kind of a rash, that papular rash, I think the earlier picture also, which was there, these are all very, to me, it looks very typical for a spotted fever rickettsioses.
How often do you actually see the vector and the bacterium or a pathogen in the same patient? It was brilliant to see the flea in the popliteal fossa. I thought it would bite and flee the patient. But here he was able to extract the flea from the child's popliteal fossa. How common is that?
So I think it's incidental. I don't think they both are related. It's not a flea. It's a tick. So this thing, for a spotted fever, the vector is actually the tick, and there'll be an incubation period of about 10 to 12 days. So, and this child has actually come after 10, 11 days of fever. So it should have been, the bite would have happened about 15 to 20 days before that. So it's very unlikely that this tick and this thing are associated. It is possible that the child has had a tick bite and caused this thing, but I don't think it's that particular tick.
All of us have dogs and cats at home, intended or otherwise, and they all are ridden with ticks. how relevant is that history that he penned, the pets at home? Would that be a differential, or would that be a point in favor of considering dyslexia?
No, I don't think it's a very relevant history, because whether you have pets at home or not, I think you can still get ticks. Yeah, I think like you said, I mean, most people nowadays have dogs and cats.
Thank you. Thank you.
Ashwat, that rash is also not typical palpable purpuric rash. I don't think HSP should be considered in this child. Rash with HSP is very classical palpable purpura. This rash is not palpable purpura and is present all over the body. And that is also not classical of HSP. So we should not consider HSP as a differential diagnosis for this child who is presenting with this type of rash.
Dr. Sendil, can you go back to the previous slide? I think the audience missed out that Will Phillips. Yeah, please.
Yes, sir. Sir, the previous investigation, almost all the investigation were done in the previous hospital. By day one, we were able to identify the tick, and my first possibility was rickettsia. I just added the slide of HSP just to point out the one fact that if the palms and soles are not involved, it could have been a close diagnosis. Is it wrong, sir?
The rash is involved in the whole body, you said. So that
Yes,
is
sir.
not HSP.
Okay, sir.
Because in rheumatology, all are typical pattern recognition. So
Okay,
the pattern has to be there clinically to make a diagnosis of HSP.
Okay, sir. Almost the
Professor
previous.
Winsley, can you quickly interpret this Weil Felix for us? I mean, how does a clinician interpret Weil Felix? Because that's often the only test that's available to most of us.
So like I said, it's a very poorly sensitive test, but here it's a positive test. So you have three antigens. I mean, basically these are all protease antigens, OX19, 2, and K. And OX19 and 2 can be positive for many diseases, including spotted fever, rickettsiosis, endemic typhus, Indian tick typhus. So these all can be positive for OX19 and 2. Whereas OXK is very specific for scrub typhus. There is nothing else which will give you a positive on OXK. And I mean, you'll find references for varying levels to be significant. In our lab, we consider more than anything, more than 80 as significant. I mean, 80 or above as significant. And it is very, very specific. I mean, if you get a 1 in 160 OX19, this is, I mean, you can almost 100% be sure that it is rickettsial illness. But if it's negative, you can't say this is not a rickettsial illness. So that's why I think the spotted fever IgM becomes important, because that's a very good test. It will have about 85–90% sensitivity.
Thank you so much. Dr. Sandil, can you wrap up your case? Tell us what you did with the child.
Yes, sir. After getting the Weil Felix test, the doxycycline was started on day 1. Ceftriaxone was stopped. Fever was passive on day 3. His symptoms resolved within 48 hours of starting doxycycline, sir.
Okay. This child was also exposed to ceftriaxone and azithromycin. I thought azithromycin was a good enough drug for rickettsia. Any thoughts as to why he didn't respond to azithromycin?
Sir, I don't know, sir. The child has received 3 days of azithromycin.
Which is good enough.
Your comment, please, on azithromycin and cross-spotting.
I think we should consider doxy to be the drug for rickettsial infections, whether it be scrub typhus or any spotted fever. I mean, azithromycin may be useful in mild illness, but I wouldn't consider that to be the gold standard to treat any rickettsial infection. It has to be doxycycline.
Thank you. Thank you so much. Dr. Sandil, is there anything else you want to share?
No, sir, that's all, sir. The baby improved. That's it.
Thank you. Thank you for that very, very short and crisp presentation. It was truly crisp clinical case presentation. Can we go on to the next slide, please? Next presentation.
Before that, actually, there was thrombocytopenia was there in this patient. That was a
that
is not for HSP. And again, another important thing for the practitioners, the scrub typhus is mainly by mite, which can't be seen macroscopically. It is a microscopic. Only spotted fever is by tick, which can be seen macroscopically or through naked eyes. Whereas scrub typhus, it is by mite, it can't be seen naked eyes.
The case ka tick mark podlam. Dr. Thiru, is the next presentation ready? We are running out of time. We are already exceeded the time by 15 minutes. Thank you. No, this is over. This is the first. This is opening batch. We have Dr. Raju's presentation and Dr. Fauzia's presentation.
Doctor Inga.
Dr. Janaranjan.
அது முடிஞ்சு
இது முடிஞ்சிருச்சு திரு.
இல்ல முடியல சார். This not ended.
முடியல. ஜனராஜன் முடியல.
என்னுடைய இது முடியலைங்க.
Dr. Raju's presentation. Dr. Janaranjani, are you available, ma?
Yes, sir.
Can you have your presentation? Be very brief, ma. Thank you.
Okay.
Thank you.
Good evening, one and all. I'm Dr. Janaranjani from Dharmapuri Medical College. I would like to thank the IAP for giving me this opportunity. I would like to thank my HOD and Balaji sir for giving me this opportunity. My case is a 4-year-old child referred from Tirupattur GH with fever for 6 days with chills and rigors, along with vomiting for non-bilious for 3 days and abdominal pain for 5 days. There was no history of myalgia and rash over the face and the abdomen. The rash was present only after 3 days of fever. On day 4 of illness only, the child developed rash over the face and over the abdomen. It was non-itchy rash. There was no associated symptoms like cough, cold, or constipation or pain during micturition, headache, or all other histories were negative. The child was lethargic, was febrile. There was no pale or ictus. Positive findings were there was bilateral conjunctival suffusion with no purulent discharge. There was bilateral cervical lymphadenopathy, and there was rash which was present over the maculopapular rash present over the face and the trunk, and there was no eschar. On receiving, the child had a tachycardia, and we received the child in shock with a prolonged CRT and the periphery school below ankle with a BP 96/64. Child had a mild hepatomegaly and the liver span was 7.5 centimeters. This was the rash. The rash was present over the face and the abdomen. It was maculopapular rash. The rash was spread over the limbs. Primarily, on receiving the child, the primary investigations were the total count CBC was done, which showed a total count of 11,600 with a predominant lymphocytes. There was mild HB was 9.8 and the platelet count was 1.4 lakhs. The liver enzymes were mildly elevated. The RFT was normal. The acute phase reactants like CRP and procalcin were elevated. The coagulation profile was normal. So initially, our differential diagnosis was since the child had a fever with thrombocytopenia. Our initial. Sir, can I continue, sir?
Yes, ma'am. Please.
Sir, since the child had a fever with thrombocytopenia and since scrub was very common in our area, our initial differential diagnosis were dengue and scrub typhus were rickettsial infection were a primary differential diagnosis. Other differential diagnosis were septicemia and Kawasaki were and viral exanthematous fever was a initial differential diagnosis. The child was initially treated with airway stabilization, IV fluid bolus of 20 ml per kg, and the child did not require any inotrope support. It was started on piptas abicacid. Since rickettsial infection was suspected, the child was started on doxycycline on day 1 of admission. Even after the child was started on even the child had persistent continuous fever even on admission for 3 days. Already the child has been admitted with 6 days fever, and here on 3 days the child had continuous fever episodes, and the fever spikes were very high with 101 and 102. So other causes were thought and other investigations were done. UST was normal, only mild hepatomegaly was done. All the infectious etiology was further evaluated. The dengue IgM, the scrub IgM turned out to be negative. Vidal peripheral smear for malaria was normal, and the peripheral smear also showed only mild microcytic hypochromic anemia with mild thrombocytopenia. Echo was done, which echo was also normal. This case was received around 8 months back. Since the child had a persistent fever even on day 3 of admission, and even after starting of broad spectrum antibiotics, since the child had persistent high-grade fever and elevated acute phase reactants and CRP.
Dr. Janaranjani, you are losing your audio, ma.
Am I audible now, sir?
Yes,
audible, ma.
Please continue, ma.
Sir, since the child presented to had a fever for more than 9 days, along with rash, with bilateral non-purulent conjunctivitis, bilateral cervical lymphadenopathy, and fever unremitting to broad spectrum antibiotics as well as doxycycline. Other differential diagnosis like inflammatory with Missy and Kawasaki was kept in our mind. Echo was done, which was turned into normal. COVID antibody was done, which was turned positive. So our diagnosis, primary diagnosis here was Missy, sir. The child was started. Yes, sir.
Dr. Jananji, we will take a pause and take Dr. Sati's opinion. He's only made a very pertinent point considering how common subclinical COVID infection is. Are we going to see more and more diagnosis of Missy purely based on the antibody titers, Dr. Satish? Is that a fear?
Yeah, so that's the previous case also I said. So kindly rule out all the tropical infections and other conditions before you label them as Missy and you treat with steroids. So this child has come with shock, and we already said most of the children are vaccinated, and all of them are either vaccination or by the infection. Almost every child has got antibodies are going to be positive. So don't make your diagnosis based only on that antibody. Kindly rule out all the tropical infections before you label somebody as Missy. And even if you consider Missy, this child is presented with shock to you, the ideal dose of steroids should be 10 milligram per kilogram than 2 milligrams. And IVIG also is part of that for children presenting with Missy with shock.
Okay.
And IgM and COVID antibody IgM is positive. Correct. Yes, and this child was diagnosed recently or sometime back during the last year, January?
Around 7 or 8 months back, sir.
What was the ferritin level, ma?
So the ferritin was elevated, sir. We didn't have a...
Because why can't it be a HLS, infection-induced HLH, Wesley Rose can throw?
So the child didn't have... HB was 9.8. The child coagulation profile was normal.
Counts were normal, sir, in this case.
Yeah. Yes. Platelets were also normal, sir.
No,
near normal.
It was 1.2 lakh, sir. Repeated also, it didn't decrease much, sir.
Okay.
Yeah.
And what about the strong family history? Both the grandparents were COVID positive. At that time, child was with them, sir. Child had initially mild fever during that period. When we asking the past history, they gave this history, sir, which give clue that we are dealing with Missy in this case, sir.
Okay.
And we ruled out all the other tropical infections, sir.
Yes,
like
sir.
Dengue,
yes, we have done all investigations.
rickettsials, everything is negative. Yeah. But be very careful before you label anything to this COVID nowadays.
Thank you, Dr. Jananji. Dr. Satish, thanks for the delightful inputs. Can we quickly go on to the next two case presentations and we can wrap it up? Dr. Thiru, we can have.
Thank you, sir.
Thank you, Dr. Balaji.
Thank you, sir.
So thank you very much, sir.
Have we done this case?
From Dr. Partha
Not yet.
Vikanam Hospital under the guidance of Dr. Fauzia Mol. Dr. Partha, can you start your presentation, please?
Yes, sir. Can I start, sir?
Yes, please.
Yes. Good evening, everyone. I am Dr. Partha, first year DNB resident from GKM Hospital. Sir, can you all hear me properly, sir?
Yes, yes. You're audible. Please go.
Sir, this is a OP case seen by our consultant, Dr. Fauzia, ma'am. This is a 4-year-old boy born out of a non-consanguineous marriage. He's a developmentally normal child. He presented to us, to our OPD, with the history of recurrent episodes of fever. And each time with the fever, he had a nasal discharge and cough. These fever episodes started after the child started going to school. And each time these fever episodes lasted up to 2 to 3 days and maximum up to 5 days. And for past 4 months, the parents also noticed an erythematous rash over his, which initially started over his face and slowly progressed to trunk and limbs. And these rashes were migratory in pattern, and it lasted only few hours, maximum a day. And sometimes the parents gave a history that these rashes came even without fever. Next slide, please. Yeah, and there was a particular history of 2 episodes of pain and limping of his both his lower limbs in the month of December. That is 2 months back. This started after almost 3 months of these repeated fever episodes. And on the first episode was treated on the first day one itself with ibuprofen and prednisone, and the child recovered completely. And the second episode, the parents said only lasted few hours, and the child did not need any medications to recover from that thing. And he actually presented to us at the end of the December. And he had oral ulcers with peeling of lip for past 1 month, that is during the month of December. And he also had persisting fatigue for 1 month. Next slide, please. So on examination, he's a well-nourished child, and on the day of presentation, he was febrile, and he had a non-significant bilateral cervical lymphadenopathy. To describe this rash, it was an erythematous rash which was palpable, non-tender, and it was pruritic. It was noted over his, at the time of presentation, we noted it near his ear. And the parents also gave the image which was present previously, which showed the rash over the right arm. We don't know whether it is clearly visible. And on examination, he had mild bilateral V's. His other system examinations were normal. Next slide, please. His initial investigations, the CBC showed a mild elevated platelet thrombocytosis around 5 lakhs. Even on his repeated CBCs, which was repeated later in the January, also showed the persistent thrombocytosis within the range of 5 lakh to 5.5 lakhs. His ESR, which was done outside during his previous episodes, was 120, but when we repeated it in our hospital, it was only 8. And his CRP was also normal, 2.9, and the creatine phosphokinase was also 70. Among his organ functions, he had only low levels of serum globulin in LFT, but all other LFT were within normal limits, and even his immunoglobulin profile was also normal. Initially, what we thought was an allergic bronchitis.
Dr. Parsati, can
Yes,
we
sir.
take a pause here and invite Dr. Sati's opinion? We are here now dealing with a very different phenotype than what has been described so far, in the sense the child has got recurrent discrete episodes of fever with rash, with very
Yes.
little other organ involvement. I mean,
Yes,
we
sir.
have been constantly being told about our autoimmune and autoinflammatory. Can
Yes.
Dr. Satish please elucidate on when do we suspect autoimmune or autoinflammatory conditions? What are the autoinflammatory conditions that a practicing pediatrician is likely to see? What are the clinical pointers?
Yeah,
Thank you.
sure. So this child has got fever. So systemic JA is very easy to diagnose because the fever occurs almost every day. Unless you treat, it won't go back like in 3 days, 4 days, it doesn't go. It will persist more than 2 weeks. Then the rash is very classical, which comes along with fever. When the fever goes away, the rash goes away. And the child will become normal in between the afebrile period. So that is a systemic J where you have high ESR, high CRP, neutrophilic leukocytosis, thrombocytosis. Second, but this child has got, every time has got an upper respiratory infection along with fever. And the rash, you also said sometimes it is not associated with the not associated with fever also. So systemic JA goes down for this child. Whether it's some form of allergy with URI could be a possibility. So when you talk about autoinflammatory syndromes, they come with fever and they don't have URI symptoms every time. And they can have periodicity, especially with familial Matrix fever and all those things they have typical. So usually they have high-grade fever, and the rash is usually a maculopapular rash, comes along with these episodes, and they can have arthritis, they can have abdominal pain, all those things can happen. So this child doesn't have this typical of autoinflammatory. So if somebody comes with recurrent fever without any localizing symptoms, they can have abdominal pain, they can have arthritis, they can have rash, and it can be comes as a recurrent and it comes as a periodicity. Then you should consider autoinflammatory syndrome. Before that, this child, whether going to school, that's another important thing. You said 4 years, whether all these symptoms happening after going to a school. Because we have seen some children, they refer to as autoinflammatory, but the typical history, after going to school, every 2 to 3 weeks, they get some URI symptom and gets better. And you also said the child is growing well. If you have autoinflammatory syndrome, the child will not grow well. And the intermittent, and you said CRP is negative in this child. In autoinflammatory syndrome, most of the time is IL-1 or IL-6 mediated. So they have more high CRP than the ESR, or both will be high. So I think this child needs further evaluation, and this child Whether it could be a recurrent URIs along with fever after going to school could be a possibility.
Yes.
Thank you. Dr. Patsati, you can proceed with your DD and tell us what you actually did with the child.
Yes, sir. Sir, we treated each episodes of ARI being treated with amoxicillin and clavulanic acid, and we responded well. And for his URI symptoms, we treated with levocetirizine and levosalbutamol. And we sought out the opinion of Dr. Suma Balan sir from Amrita for rheumatological purpose. And he evaluated further with C3, C4 and LDH were done. So more in the normal range except for a high normal LDH. So we thought our first DD, he sort of ruled out a systemic JAA, and we considered this as a fever with, any acute respiratory infection with some kind of allergic rash. And we thought of following up the child for another 3 or 4 months, and depending on the pattern, how he presents further, we thought of evaluating further. Sir. At present, he's being treated as an ARI, each episode being treated as an ARI with NSAIDs for his pain.
Yeah, Parsad, so this child, my only thing is this child needs follow-up, whether he develops into some other disease. One thing is I saw somewhere you said prednisolone was given. So yes. I just want to tell the practicing pediatricians, everybody, please don't use prednisolone as a painkiller or as an anti-inflammatory. So we have naproxen, we can have brufen, we can have paracetamol, but don't give prednisolone without knowing what we are dealing with.
Yes, he was
rash before antibiotics or after antibiotics?
No, it was before antibiotics. He presented.
Dr. Fauzia, do you want to add anything to what Dr. Patsati said because you're the lead consultant?
Yes, sir. This case, he came to us after 3 months of getting evaluated at multiple places outside. So he didn't fit into a typical pattern of infection-related rash. His clinical features and his lab parameters did not show any inflammatory features also. But his rash, as per his parents, is responding to antihistamine, levocetirizine. With levocetirizine, the parent says his number of episodes of rashes have come down. So we are actually thinking in terms of any food allergy or anything. So we've given them a diary to note down in detail when the rash comes and to note down what food he's been taking, and they're doing it. They kind of report each week what is happening to the child. So we're planning to follow him up. And also, as Satish sir said, we'll have to see the evolution for any familial periodic fever. That is also at the back of the list of DD, sir.
Fauzia, if the rash is persisting, do a biopsy. If the rash goes by 2-3 days, don't do. The rash is persisting because in autoinflammatory syndrome, we typically have neutrophilic vasculitis like rash in the biopsy.
Okay, sir.
So please keep that in mind and follow this child.
Sure.
Dr. Ashwath, if I'm permitted, I just wanted to know, because this rashes are raised, they look atricarial hives-like, and therefore, and there is a response to histamines. And many a times the rash happened without even the fever episodes. And she said the rashes are also very transient. Sometimes they go away in a few hours or even less than a day. So I think there is high possibility of, and you can also have urticaria, you can have joint manifestations, some joint pain and other things. I think this, as Dr. Satish said, this child requires a close follow-up.
This is an evolution probably, ma'am.
Yes.
Febrile urticaria, serotonin induced should also be thought of.
Sir, one small
Thank you, Dr. Patsati, and thank you, Dr. Fauzia.
One question to Dr. Satish. Is there any pointer to pinch out, that is whether it is autoimmune or autoinflammatory, that particular fever with rash, sir? Any pointer, sir?
So exactly, sir. Sir, that's what I told. So the fever coming, sometimes in few diseases, we have this periodicity, FMF, traps and hits. So these 3 things have periodicity. Other autoinflammatory syndrome doesn't have periodicity, but it comes and goes, and they will have high ESR, high CRP. They can have rash. We have something called arterial vasculitis also. And the other thing is they can have abdominal pain, eye changes, and the rash will be persisting, myalgia, arthralgia, and most of the patients will have failure to thrive because it's autoinflammatory diseases. They have innate immune system problem. So they all have a lot of cytokines released in the body. They will have, and important is the family history, failure to thrive. Last month, we had a child from Coimbatore admitted multiple times in JKNM with high ESR, high CRP. So this child was referred to us whether it is an autoinflammatory syndrome. We did a genetic mutation. We couldn't prove that child had to be genetic. But the family history, interestingly, this boy's brother has married the mother's sister. So both the brothers has married the sisters in the same family. They're not consanguineous. The other family's child has got same thing, fever, and this child also has got abdominal pain, and that child's mutation came as hyper IgD syndrome. Very interestingly. So this family history is very, very, very important. When you discuss about most of the autoinflammatory syndromes are autosomal recessive.
Since this is the allergic disease, many times we do the IgE, sir. At what level, cutoff level, we can diagnose hyper IgE?
Winsley, you want to take this question? I don't do IgE.
No, I think you said hyper IgD, no?
This child has got hyper IgD syndrome. Hyper IgD, HIDS, HIDS, melanomate kinase deficiency. So one child was mutation positive, this child was mutation negative, but this clinical presentation is same. Then the father finally agreed this is not infection, it is inflammation. He stopped going and get admitted for IV antibiotics every time ESR CRP goes high.
Thank you, sir.
So we'll move on to next case. Yeah.
Dr. Raju?
Yes, my PG.
Sir, sir. Later on the latest
batsman. Super hit.
Last batsman.
நான்
Cameo.
ஒரு தடவை தூங்கி எழுந்துட்டேன். Sunday night.
எங்களை தூங்க விட மாட்டீங்க, அதான் ப்ராப்ளம் உங்க பிரசன்டேஷனோட. Sir, over to you, sir.
PG was there. At Priyadarshini?
Good evening, sir.
Yes.
Dr. Thirumurugan, please.
Sir, presentation is WPS. Dr. Priyadarshini, can you share your slide presentation from your system, ma?
Wait a minute, sir.
Screen share பண்ணிடலாமா? Dr. Thirumurugan, I have sent the presentation again from Dr. Priyadarshini to you. Can you please check up in your WhatsApp? Share out.
Yes, it's coming.
Yes, sir.
Yes.
Perfect.
Okay.
Super. Sir, please.
Good evening, everyone. Thank you for this golden opportunity. My presentation is about a 5-month-old male child coming from Tengasi. He was referred with history of fever, which was high in grade, intermittent in nature, and it was not associated with chills, which lasted for around 3 days. He also had a history of fever, which was sudden in onset, dry, sometimes wet in nature, intermittent in nature, associated with he didn't have any post-acid vomiting. And he had a history of vomiting, which was intermittent mucus consistency, and it was not associated with blood or bile. History of increased work of breathing was present for 1 day, and he also had a history of refusal of feeds for 1 day. On admission, the child was in septic shock and with moderate respiratory distress. For their septic shock, a fluid resuscitation followed by inotropic support was done. For respiratory distress, the child was started on HFNC and then shifted to PICU. The chest X-ray showed right upper lobe consolidation. Blood investigations were suggestive of sepsis with high blood counts, high CRP and procalcitonin with DIC coagulopathy. Next slide.
The child had a skin lesion on day 2 of admission, which started as an erythematous indurations over groin and right thigh, which progressively enlarged with central black necrosis. The clinical suspicion of SR was made. Initially, we thought it to be strep typhus, and the child was started on IV azithromycin. As the child had septic shock, other empirical antibiotics like piptaz and vancomycin were also added. Then, in due course, the HFNC failed, and so the child was intubated and mechanically ventilated. During the PICU stay, the child required high ventilatory pressures. So the diagnosis of moderate ARDS was made. And also the child had the repeat X-rays showed a persistent right upper lobe collapse, for which bronchoscopy and lavage was done. The blood culture and the bronchoalveolar culture, lavage culture, showed Pseudomonas aeruginosa growth, which was pan-sensitive. Thus, the skin lesion which we saw was confirmed to be ecthyma gangrenosum. Then the course in the hospital, the child would be the child had fluid overload, which was refractory to diuresis, and also the child has had a respiratory and metabolic acidosis, for which the child was started on peritoneal dialysis, and it was continued for 72 hours. In due course, we achieved fluid removal, and the child was weaned off ventilation to HFNC on day 7 of admission, and then to room air. The child was treated with IV meropenem and clindamycin for 14 days. The child improved, and the child was shifted to room ward. Skin lesions gradually healed. Repeat sepsis markers were negative. The child was discharged after 3 weeks of hospital stay. Then workup for cystic fibrosis and immunodeficiencies were done, which turned out to be negative on follow-up.
Dr. Priya, can we just take a pause here and take Dr. Winsley's opinion?
Okay.
Professor Winsley?
So I think the lesion is very, very typical for ecthyma gangrenosum, and the lesion doesn't look like an eschar, which is because of strep typhus. So I think that's where the money is, that the description of the lesion. And to find Pseudomonas, I mean the most common organism associated with the ecthyma gangrenosum is Pseudomonas, and I think everything just fits. The only thing is, why did a child who is 5 months of age, otherwise healthy, develop ecthyma? I just wonder whether the child was treated somewhere else before they came to this hospital, because sometimes it can be a hospital-acquired infection, if not infection. I mean, if you, I know you're already evaluating for a primary immunodeficiency. So, but even sometimes just hospital-acquired infections also cause a similar issue.
I think it was a 2-day stay in some other hospital.
So the other considerations when you have an eschar, I think another thing is anthrax. I mean, I know we don't see anthrax so much, but like, I have seen a child who was presented with an eschar and it turned out to be anthrax. Child died within 6 hours, came with seizures and all that. I mean, other than this ecthyma, strep typhus and anthrax, I can't think of, I mean, African tick typhus causes an eschar, but then we don't have African tick typhus. So, but other than that, in our locality, I don't think there are any other lesions which produce an eschar. I mean, if there are any other comments, I'm happy to.
I had seen anthrax in not in a child, but in a person who was working in a veterinary hospital. So that I had seen. I didn't have the follow-up of that person. That was long back. And another thing was psittacosis. One medical student, first-year medical student in a private medical college. She came with prolonged fever with the SR-like picture, but it was not a big SR. It was not much of a depth. It was a superficial thing. And she gave classical history of having contact with pigeons. So later had antibody, the PCR positive, and she was treated. She also had. But how to differentiate clinically this and the ecthyma gangrenosum, scrub and this?
So scrub typhus, the eschar is very small. I mean, it's probably about 0.5 centimeters in size. Ecthyma is usually
so
much
broad,
larger, and it's got a
broad.
punched out kind of appearance with thick black eschar. Yeah, the scrub typhus eschar is much smaller, and ecthyma you can have more than one lesion. Whereas with scrub typhus, I mean, you get only one eschar.
One
Whereas
or two.
with ecthyma,
Child-
you'll have more.
Child will be very
And
sick with ecthyma.
pain and painless, sir. Can it be? Because ecthyma is a more painful thing. Whereas
Child will be very, very
typhus, in
sick.
fact, people don't even know that they have the eschar because the lesion is hardly painful.
No, ecthyma child will be very sick clinically.
No, even scrub typhus also can be sick because of
No,
the
they can come as outpatient
Yeah.
also, but
Only
ecthyma
thing, the
is very-
eschar is never painful because they hardly, you have to make out the eschar, search for the eschar. Whereas ecthyma is something which evolves, it will ulcerate in front of you. Whereas in scrub, it would have already ulcerated when they come to you.
And the induration and extension is not a feature of eschar.
Yes.
Induration and extension is not a feature of eschar.
And eschar is hardly painless. Whatever you see, it's painless.
Dr. Raju, any other opinions, sir, or can we wrap up?
that is the thing.
Very, very
That
well
is-
managed, excellent.
Yeah, we could get the BAL as well as the blood specimen positive for Pseudomonas, so that's why we could make it.
Absolutely. Thank you. There's a question
Why
on
Clinda,
drug
sir?
of
Why
choice for Pseudomonas.
Clinda for 14 days? Clinda?
I think my son treated. He's a pediatric intensivist, so he treated. So I can enter.
Very nice.
Dr. KR?
Yeah, it's really the first meeting is really good, and I think it's with the short notice we are organized. I think a lot of some problem was there. I think from next meeting onwards, I think we will sort it differently. Within 20 days, we will make it completely clear out. And I think next one is we are having on February last Sunday. We are having next, and this is topic is on child with limp. We will plan for child with limp. And another thing is, I request all the presenter to write at least one page, write up to our IAP TNSC or IAP TN activities at gmail.com, and we can have an e-bulletin. I think Dr. Thirumurugan is planning every 3 months, I think is may publish the e-bulletin also. And once again, on behalf of IAP TNSC, I thank today's all presenters, and I think it's stalwarts like Dr. Winsley, Dr. Satish, and Dr. Paliraman.
Excellent.
Very well. And I thank Dr. Aswath, and actually we have, it's actually past 15 days, we are having discussion. Shall we proceed this pediatrician, practicing pediatrician oriented case presentation. I think this really almost 230 members attended. It's really happy that it's on Zoom only. I think many a person attended in the live YouTube live also. And really, I thank each and every one of you. I thank IAP TNS to give this opportunity. And now I call Dr. Thirumurugan, IAP TNSC Honorary Secretary, to deliver a vote of thanks.
Sir, one small doubt, sir. Maybe a basic doubt.
Yeah, please.
To the experts, if you don't mind. Sir?
Yes, boss.
Sir, how come this scrub typhus and rickettsia have increased so much for the past 5-6 years, sir? We are not seeing it before 5-6 years. How come it has increased so much, sir?
Winsley, boss.
Awareness.
How come this rickettsia and scrub typhus has increased so much? It has the flea flood.
We are invading my territory. That's also.
We are going to forest.
We are going to my territory.
Is it a bio war? Is it a bio war?
Mainly lifestyle changes and urbanization and everything made this, sir. And more diagnosis also, one more thing add this, I think, sir, actually.
Urbanization should decrease, sir. Scrub we don't get in urban.
Sir, if you, I mean,
awareness and also
Dr. Winsley, please. Dr. Winsley.
No, I'll just give my opinion. So we actually about 20 years ago is when we published scrub typhus, 2 case series on scrub typhus about 20 years ago from this thing. So it was in 2002. So since then, 10 years later, we published another one where we have about 5-year case series where we have about 500 patients. So obviously it is actually definitely increased much more than what it used to be. The scrub typhus was always there. Scrub typhus actually was there in the Southeast Asian jungles. If you actually think about
Triangle.
yeah, I mean, that's the Tsutsugamushi triangle. But in Southeast Asia, it was there. Northeast, it was there. It was during the Second World War where when it was actually very prevalent. In fact, a lot of the Japanese soldiers died because of scrub typhus during that time. But after that, we haven't had scrub typhus for about 30-40 years. And over the past decade, like you said, I mean, like 10-20 years, it's actually had a great increase in the cases of scrub typhus. This is not just here, it's all over the country. And so one reason I think is the mite population which is there. Mite population has always been here, but the mite population is now infected with Orient share Tsutsugamushi. And that I think is related to travel and the rodent population, which is actually sort of transmitting it from one to the other over a period of time. I mean, I think all of this has contributed. And its scrub typhus has now been reported from Middle Eastern countries, from Africa, from South America. So there is definitely an increase in scrub typhus over the past 10-15 years.
Thank you so much, sir. Thank you.
Thank you for that insight.
Okay, thank you, sir. I think we are off to a great start with the next to impossible task of cramming in so many cases together. Originally, I think we planned only for 5 cases, but and we kind of had an agreement that we would agree upon having good quality cases, all good quality cases in, and at the end of it, we have had a lot more than what we planned, which probably is the reason why we shot off by about more than an hour. I think this is a process by which we are trying to fine-tune our presentations, but I'm very happy on behalf of IAPT-NSC that we have had a very fruitful discussion. And after a long time, we have had more than 100 members actually. I think the last one, previous one, we had about 130, and now we have had more than 200. It is very impressive. It shows the kind of interest for a program of this nature. And for that, I should thank our academic coordinator, Dr. Rajendran, and for organizing, coming up with an idea. My original idea was to discuss journals, and where he came up with this idea, and I think it was very well received. So thank you very much, sir. My thanks to Dr. Ashwath, again, doing a difficult job of trying to coordinate so many people who are experts in their own right, and to get the best of the lot, Dr. Winsley, Dr. Satish, and Dr. Palniraman, to discuss something so elegantly, and then I mean their knowledge is phenomenal. So I thank each and every one of them for being there. I thank each and every the other members, Dr. Sridev Narayan, Dr. Balaji, and Dr. Raju, for coordinating all the cases and then getting a very nice evening for us. And all the presenters, IAPT-NSC is very thankful to you guys for making sure that we are exposed to a plethora of cases which probably we won't come across in a single setting, and also in a manner which is well worked out. So I think we are definitely delighted to have such a presentation. Last but not the least, I think let me thank our 3 presidents, the present one, Dr. Suresh Balan, our immediate past president, Dr. Ramesh Babu, and of course our president-elect, Dr. Professor Balashankar, for coming up with these ideas and then giving a nice shape to it so that we are able to enjoy this session. So thank you, everybody. These sessions are planned for the last Sunday of the month. So because last month we had the EB meeting, it got postponed. So we would again see you guys again by the end of this February for one more allotment of the 4C series, which I'm sure is going to be very useful to all. So hopefully we'll have it on time next time. with a much more fine-tuned version. So thank you very much, and then hope to see you next time. Thank you. Bye.
Thank you. Thank you.
Thank you. Thank you.